Hey everyone. Today we're going to be going through the PEDS emergency conditions for your matrix and the upcoming exams. So here's what we'll go through: some R1 conditions and one R2 condition. So the first R1 that we'll go through is management of the seriously ill child. Um, this is a massive topic that we could speak about for a long time, but um, a lot of the different conditions that will lead to a seriously ill child um, have been covered in other Muppets lectures, which I encourage you to check out. So I think with management of a seriously ill child, it's first important to consider what are the causes of a seriously ill child. Most commonly, it's going to be some kind of infection, whether it be viral or bacterial. So viral infections are very common, 10 to 12 episodes per year in toddlers. Kids that are going to school or daycare are at a much higher risk. And these are normal, help to, I guess, strengthen the children's immune system, um, and are generally not too worrying. Um, in terms of viral infections, that can be quite dangerous. Um, a lot of these viral infections, it's important to consider that, whilst viral infections are typically not as serious as bacterial infections, the symptoms should be considered. So, if a child is to have, pneumonia, it doesn't matter whether it's viral or bacterial. The management is key. And children that do have viral illnesses, can be at, you know, quite a big risk of deteriorating quickly as well. In terms of bacterial infections, um, 7 to 25% of febrile illnesses in children are due to serious bacterial infections, which is particularly relevant because sepsis kills. So some common and not so common causes of bacterial infections include pneumonia, meningitis, otitis media, septic arthritis, cellulitis, and abscess. Um, a key takeaway from this slide in terms of managing a viral versus bacterial cause is that paracetamol and ibuprofen typically um, will reduce a fever in a viral cause, but won't as well in a bacterial cause. So, if a child has a temperature of around 40, giving paracetamol should um, cause a drop in that temperature if it is a viral cause. Whereas if it's a bacterial cause, it won't drop as quick. Some risk factors for serious bacterial infection. So again, in terms of exam questions, things that might pop up, which should have alarms bells ringing. Immunization, as we all know, considerably higher risk in unimmunized children, particularly of some, quite serious conditions such as, meningococcal um, disease. Another one is recent antibiotics. So another one to look out for in stems of questions. Children that have recently completed a course of antibiotics, and therefore, might have symptoms that are being masked by this antibiotic use. Higher fever, again, it's not specific for sepsis or a serious bacterial infection. However, something to consider if you're given paracetamol, especially, and that temperature is not dropping. Also important to recognize that children can be hypothermic or febrile and still be septic. Um, and typically, in terms of vital signs, respiratory rate is the first one to change when a child is septic or unwell. Management, again, kind of maintaining that same approach that you would with anyone, the A, B, C, D, and don't ever forget glucose as well. So, oxygen and airway support, securing an airway, early IV or IO access in children, fluid resuscitation if necessary, um, and as well important to recognize as well that in fluid resuscitation, we typically give dextrose as well in children to correct hypoglycemia. And you want to be aiming to start antibiotics as soon as possible. That means, not necessarily waiting for a positive result, a positive culture, or anything like that, you want to be starting antibiotics as soon as possible. So investigations do have some role in a seriously ill child, but as mentioned before, um, you know, for example, urinalysis, for example, is not 100% accurate. CRP may not rise straight away. Um, you know, if you're considering a lumbar puncture, you would still want to start antibiotics before, doing this. So I think key is just to recognize that, whilst investigations do have a role in management of a seriously ill child, um, starting empiric antibiotics early is key. Um, so, if there have been, so you still ideally do want to, um, take cultures and do relevant investigations, but you should not be waiting for results to start antibiotics. And in terms of what antibiotics to use, typically a third gen cephalosporin, um, such as cefotaxime or ceftriaxone, as well as gentamicin and staph cover can be given. In cases as well where you are concerned about potential viral cause, for example, a viral meningitis, you'd also give acyclovir. And just some other things to look out for in terms of your exam questions and things that might pop up um, of red flags. So vomiting without diarrhea, you should be concerned about a potential surgical or an acute abdomen, as typically, vomiting should be present with diarrhea and gastro, which is quite common. However, there's vomiting without diarrhea. This should raise concerns and, probe further investigation. Rigors are specific for gram-negative septicemia, bilious vomiting, so gripe brain vomiting, biliary obstruction. Non-blanching rash, you should be concerned about meningococcal meningitis. Other things too, in terms of general inspection, floppiness, a weak cry, irritability, and poor, response to the surrounding environment, you should be worried about sepsis. Um, in terms of your A, B, C, D, E, I'm not going to go through all of them super quickly because we'll touch on some of these things, but feel free to have a read of just some signs that will come up. So airway, you'd be worried about signs of any acute upper airway obstruction, and that would, be indicated by a stridor or drooling. In terms of breathing, signs of increased work of breathing. So, looking at chest rise and fall. Is there any abdominal breathing? Any, subcostal recession as well. Um, circulation as well. Um, you know, is this child well perfused or is this child mottled and quite cold peripherally? Um, and your DEFG. So again, looking, checking neurological signs. So looking at the eyeballs, um, looking for reflexes if you are concerned about a potential meningitis, and of course, checking glucose as well. Cool. We'll move on to anaphylaxis now. So anaphylaxis is a severe allergic reaction characterized by an acute onset of cardiovascular or respiratory symptoms. So typically it's associated with skin features. So you'll see, a quite prominent urticarial rash, erythema, and angioedema, and persistent severe gastrointestinal symptoms. So to understand what anaphylaxis is, it's important to, I guess, kind of recap allergic reactions. So anaphylaxis is a hypersensitivity reaction, so a type 1 allergic reaction, um, where there's an initial sensitization with, this offending agent, and then, in further events where this person is exposed to a particular allergen, that results in a severe, hypersensitivity response from the body. So risk factors include, atopic triad, so eczema, food allergy, asthma. Typically, kids that, have anaphylaxis will also have, some of these other conditions. Common causes of anaphylaxis include food, so nuts, dairy, some fish. Also, insect bites can cause anaphylaxis, some medications, and some other things too, which are listed. Important to note that a cause is not always identified for anaphylaxis. So how does it present? So there was typically a trigger of some sort, whether it be food, um, and the anaphylactic reaction will occur um, quite soon following this exposure. So there are the typical skin features, um, including the urticaria, flushing, and/or angioedema, plus involvement of the respiratory system, cardiovascular system, or gastrointestinal system. Um, it is possible to have anaphylaxis if these typical skin features are not present. However, it's um, in most cases of anaphylaxis, there will be these typical skin features. It's also important to recognize how we differentiate between anaphylaxis and a mild allergic reaction. So, whilst a moderate allergic reaction, you'll still get hives and swelling. It won't be widespread over the body. It will be kind of localized to the area, um, where that exposure was. And be it won't be complicated by, these respiratory and cardiovascular complications as well. In terms of management, removing the allergen if it's still present. So if it's, a food or an insect, removing it, um, laying the child flat. So again, as you can see their position, so laying them in the supine position or on their side, and then giving adrenaline as soon as possible. Do not delay adrenaline. So as soon as there's suspicion of anaphylaxis, you want to give it straight away. No need to, you know, do any investigations or anything like that. It's better to give it and it's not anaphylaxis than to not give it. Because again, with these, respiratory and cardiovascular systemic symptoms, children can arrest quite quickly. So adrenaline works, it reduces some of the mucosal edema in the airway. Um, Also, induces bronchodilation and vasoconstriction, um, and helps. So it lasts. It works pretty quick, and its maximum effects last around 15 to 20 minutes. If there's no response or a poor response, you can give another dose after 5 minutes. And if there's still not much response after a second dose, important to consult ICU to consider adrenaline infusion. The dosage is 0.01 mils per kilo of 1 in 1,000 adrenaline. So, for example, in a 20-kilo child, you would give 0.2 mils of 1 in 1,000 adrenaline. In a 30-kilo child, 0.3 mils, and etc. EpiPens have zero point 0.3 mils in them. And again, in these emergency situations, often, there isn't much dosage calculation done as, um, key is to, I guess, administer adrenaline as soon as possible. And this is just a kind of summary of that flowchart of what we do. Um, Important to recognize as well that children with anaphylaxis should be observed for at least 4 hours. So if a child comes into ED with anaphylaxis, they should be monitored for a 4-hour period before going home. And how do we manage a mild reaction? So we use non-sedating antihistamines, which help with some of these symptoms associated with anaphylaxis too. Important to note that we do not use first-generation antihistamines because this can cause drowsiness, and it's hard to differentiate between this drowsiness and anaphylaxis. An anaphylaxis action plan is also a key thing that is done. Moving on to poisoning and accidents now. There are lots of different, pediatric poisonings. We're going to focus on the main ones. So paracetamol overdose is one of them. So it's single acute ingestion of 200 milligrams per kilo or more than 10 grams. These children require urgent assessment. And it's important to get a good history to, I guess, get an idea of exactly how much paracetamol has been ingested, type of paracetamol. These children are often asymptomatic, however, can have right upper quadrant tenderness and hypotension in some cases. In terms of investigations, you want to do a serum paracetamol level at 4 hours post-ingestion. So, if someone's come in with, um, 1 hour after paracetamol ingestion, um, you would want to do that serum paracetamol level 3 hours after that. In terms of management, this is where the plot nomogram comes in. So this can be used as a means of determining if acetylcysteine is needed. So if you plot the paracetamol concentration and it's above the line, you are to start acetylcysteine. If it's below the line, you just watch and wait. Um, Time equals lever, so it's important to um, have some early administration of acetylcysteine to reduce, the risk of liver injury. So acetylcysteine is, um, it's compatible. It can be diluted with any fluid. So often given with, 0.9% sodium chloride or in 5% glucose. Um, and yeah, monitoring, I guess, these children over time is key too. Important to note, activated charcoal has a limited role, um, mainly due to compliance. It's not as easy to get a child to drink activated charcoal than it is to start an acetylcysteine um, infusion. So that is why. Iron poisoning, another one that's quite common. Um, Important to note the presentation changes depending on um, how far or how much time has passed since ingestion of iron. Management's typically supportive care to correct GI losses and address shock. However, desferrioxamine can be used if there is, a more serious, um, I guess, reaction to this. Moving on to common fractures. So before we start talking about specific fractures, it's important to note the anatomical difference between a child and adult. Um, so in an adult, you only have um, the diaphysis and the metaphysis, whereas in children, you also have um, the epiphysis and physis, the growth plate. Um, so this is important in terms of when we consider what happens when an adult gets injured. So, if as an adult, if you were to fall on an outstretched hand, you'd be more likely to experience, a dislocated shoulder. However, a child would experience a clavicle fracture. So I guess the key point to remember from the slide is that in children, sprains, ligament damage, it can happen. However, more often than not, there'll be a fracture. Um, so in terms of mechanism of injury, children have fractures, adult have sprains or ligament damage. There's a heap of different fractures. We're just going to go through some key ones. So supracondylar fractures above the condyle, essentially, it's the most common elbow fracture in children, occurring between 5 to 8 years of age, often caused by a fall onto an outstretched hand. Um, so important to determine um, how bad this injury is. So often, if it's a non-displaced fracture, children will have immobilization in a back slab for about 3 weeks. However, in these more serious fractures, um, there may be needed a surgery needed. Um, if these fractures are displaced. Um, Important to also look for potential injuries, so radial nerve injuries. So, um, as the radial nerve runs around the condyle, documenting and see if there's any injuries of that. Um, in terms of fracture patterns in peds, um, two fractures that occur in pediatric populations that don't really in adult populations are buccal fractures and green stick fractures. Um, so a good example of a buccal fracture is a fall onto an outstretched hand. So that's an axial force. So, when you do fall on your hand, that load travels up the forearm, and then that causes pressure in the distal radius, which compresses and then buckles. So, like we spoke about before with the supracondylar fractures, distal radius buckle fractures are quite common. Green stick fractures are more of a bending force rather than a axial force. So if you were to fall directly onto your forearm, that leads to, or you have a direct blow to the forearm, that causes bending, and the tension side of the bone snaps, which is what leads to these green stick fractures. So, for example, if a child falls off monkey bars, this is, more likely to cause a green stick fracture of the radius of the ulna. Um, cool. In terms of um, fractures, it's also important to recognize the Salter-Harris clarification, which is to do with the growth plates. So the growth plates or the physis um, can be affected in fractures. And it's important because, um, in these type 3, type 4, type 5 Salter-Harris fractures, there's a risk of growth arrest. Um, so yeah, this framework helps to predict risk of growth disturbance as a result of fractures. So um, type 1 fractures are straight across the physis, uh, and type 5, for example, uh, involve have a greater involvement of the physis and metaphysis and can lead to growth arrest. So type 1 fractures only affect the growth plate, whereas type 2 fractures occur above, so they occur through the physis and metaphysis. Type 3 occur through the physis and epiphysis. Type 4 are a fracture through the metaphysis, physis, and epiphysis. And this crosses across the entire growth plate, so there's a higher risk of growth arrest. And type 5 is a crush injury epiphysis, so this has the worst prognosis. There's also a mnemonic there that you can use to remember which part of the growth plate is affected. Another common type of fracture is a clavicular fracture. So 50% of these occur in children under 7 years old. They heal quickly and fully most of the time too, and are most often due to a fallen outstretched hand or direct shoulder blow. Um, Typically presents as pain, swelling, tenderness, and a mechanism of injury consistent with what we've spoken about before. Um, and you can often see a kind of bulge sign as well as you do in that image. Um, the middle, so the middle clavicular fractures usually heal pretty well with conservative management. However, the lateral and medial fractures um, need typically a bit more careful assessment and, can be unstable and may need orthopedic review. Important as well for medial fractures to assess the brachial plexus and vascular status too. As I said, mid-shaft fractures normally heal quite well conservatively, so just a broad arm sling for 2 to 3 weeks, and analgesia. In terms of when to refer to orthopedics, you want to refer for open fractures, displaced fractures, if there's any neurovascular or skin compromise, or if there's any older children with completely displaced midshaft. So what you can see on the right there. X-rays typically the form of imaging used. CT scan can be used in medial third fractures if you're worried about, mediastinal involvement. However, typically an AP X-ray is used to assess, the degree of displacement and fracture. Moving on to child abuse and neglect, just a quick um, heads up before we go through these slides. Um, these may be some slides, um, which um, can cause distress. So just a word of warning that we'll be covering, some daunting material in these slides with themes of physical assault, medical child abuse, emotional abuse, and sexual assault. In terms of how we manage child abuse and neglect, so first is suspecting, physical harm or non-accidental injury, documenting this very clearly, and interpreting a pattern of injury. it's important as well to um, assess, the child's psychosocial situation, and report to child protection if necessary. And this requires, if you are to do this, that would require you to tell the parents, what you're doing as well. Um, there's quite a low threshold for admission when dealing with an injured child or suspecting, non-accidental injury. Um, so we can be reassured most of the time that there is not a non-accidental injury in cases where the carer recognizes the injury, seeks aid quickly, tells a consistent story, and identifies an event consistent with the magnitude of the injury. If any of these four criteria are absent, the likelihood of abuse rises substantially. Um, Yeah, and just on the right there, you can see some common areas where children are injured. So accidental injuries typically, involve bony prominences, are in keeping with, the developmental age of the child. So, children that are crawling are more likely to have, bruises on their knees and shins. And um, it's important to, I guess, um, match the injury with the child's developmental capabilities. So bruises are the most frequent observed injury in child abuse, present in up to 90% of physically abused children, and can be an early warning sign. Um, you know, where there are, bruises are quite a minor injury, but can be a sign of, potential further severe injury in the future. Um, if there is bruising, first line investigation includes FPE, looking at clotting as well. Um, so this is to um, I guess, rule out any bleeding disorders as a potential cause for the bruising. In terms of where bruising occurs normally, so again, knees and shins, head and buttock can be quite normal places for bruising to occur. If there's any bruising, in the thigh, abdomen, around the neck, um, those can be signs of abusive bruising. Um, Bruising suggestive non-accidental injury. So if there's bruising away from the bony prominences, bruising around the ears, or face, arms, back, can be signs of non-accidental injury. If there's also multiple bruises in clusters or bruising that has the shape of an object. Cool. Some injuries are quite specific for abuse. So bruising around the ear, um, can be quite a common sign of abuse. So that's one to look out for coming exams as well. Fractures are also relatively common in childhood. Again, most accidental, as we've gone through before. Um, However, 1/3 of abused children have fractures, which occur typically in infants less than 1 year old and toddlers. Again, these children are, too young to provide history. Um, so, missed abusive fractures can be quite um, damaging. So it's important to get these right. In terms of differentiating between accidental and non-accidental fractures, so in non-accidental injury, rib fractures, um, especially posterior rib fractures, can be a sign of non-accidental injury, as well as classic metaphyseal lesions, which we'll go through in a moment, scapular and sternal injuries as well. Again, multiple fractures can be a sign of non-accidental injury, as well as fractures at different stages of healing. So if we do have clinical suspicion of child abuse, and a fracture, um, some investigations are necessary. So doing a full skeletal survey and bone scan in children under 2 years old, um, or in children above the age of 2, doing an X-ray of sites where we do suspect fractures. Um, A skeletal survey in non-accidental injury is a defined set of images, and these look at the majority of the bones in the child. So there needs to be quite a thorough, discussion and investigation before this is done, because this is quite a big thing to do. Um, as skeletal surveys can be quite emotionally demanding too, and they require, well-trained radiographers. Um, cool. Classic metaphyseal lesions. So mentioned this before. Um, it's a type of fracture this that is quite subtle, um, that can be seen. Um, so it's pathognomonic of non-accidental trauma. So um, there can be a um, type of fracture that is bilateral, symmetric, um, that requires shearing forces. So again, like significant pulling and shaking, rather than an injury that is produced in accidental trauma. Common fractures, so rib fractures, like we mentioned before, they're highly specific for abuse, unless there's, quite a clear cause of injury. Um, Posterior rib fractures are most commonly the result of a force, that's an antero-posterior force. And for example, an adult, squeezing a child's chest. Um, and in the images on the right, you can see some healing rib fractures. Others to include a sternum fracture, scapular fracture, and posterior spinal process fracture. Important to note too that, you know, posterior rib fractures don't occur after CPR on a flat surface, so that should not be accepted as a mechanism of injury. Um, we have a case study here that we'll quickly go through. So we have a 6-month-old male brought in by ED, query seizure, um, been a bit unwell with a upper respiratory tract infection. Um, on examination, quite pale, floppy, lethargic, retinal hemorrhages, and a set of seizure. CT brain shows a skull fracture with acute right-sided subdural hematoma. And what this is suggestive of is something called shaken baby syndrome. So, um, I guess buzzword to remember for your exams is retinal hemorrhages. So it's brain injury symptoms consistent with vigorously shaking an infant or small child. Can lead to subdural hemorrhage, and retinal hemorrhages, and then clinically presents, with seizures and, quite lethargic. Um, Other child abuse and neglect things to consider include burns, which are also very common, typically due to scalds with hot water or contact friction. So, touching a hot pan or hot stove. Um, it is important to consider non-accidental injury in these cases too. In terms of what we do, first aid, so removing clothing and jewelry, and then quickly running the burn under cool water for 20 minutes. After that, covering it with cling film, and then, appropriate analgesia too, and assessment if necessary. Severe burns, so if the burns affect more than 10% of the total body surface area, this can lead to a systemic response, causing shock. Um, so it is important to, do a primary survey for these children, and fluid resuscitation if necessary as well. Great. Pediatric resuscitation. So this is the last one we'll go through today. Outcome of arrest depends on etiology of arrest, good and early CPR. So BLS should be done on anyone who appears lifeless. The check should, be done relatively quick. So starting CPR as soon as possible, is key. And arrest in children is usually due to hypoxia or shock. So resuscitation, so first assessing the airway and securing our airway. Then after that, moving on to assessing their breathing. So, for an infant rolling underneath their shoulder to be able to visualize, whereas a chin lift in a small child is used, or in an older child, you can put a pillow under their head. Um, so important to, I guess, recognize these anatomical differences, um, to in terms of, I guess, getting the best possible view of the airway. Um, Oxygen can be given, so you want to target oxygen saturation above 94%. Circulation, so
key thing to remember for your exams, the compression rate. Um, so in um, in children, the compression um, rate is 100 to 120 per minute, approximately one third of the AP diameter of the chest. So in children, you can do it either one-handed or two-handed technique. In infants, typically done with the two-thumb technique. The compression to ventilation ratio is 15 to 2 for children. However, for newborns, it's 3 to 1. And AEDs are also an important thing to recognize as well. Um, Again, if the patient's in VF, the only energy dose that will harm them is no dose. So if there's a shockable rhythm, important to deliver a shock, and that dose is 4 joules per kilo in children. Adrenaline can also be given, so 0.1 mil per kilo of one of 10,000 adrenaline every 3 to 5 minutes. And important as well to remember the 4 H's and 4 T's, a reversible cause of arrest. And here is a um, chart which kind of, I guess, shows this as well. Some of the steps that we've spoken about. Great. Thank you.